there's another side to the coin. And that was, Brian is a kinder and gentler Trump. A lot of distraction and diversion. Look, over there, it's a myeloma. Look, over there, hepatitis C. One specific target. We don't quite have that in inflammatory bowel disease, and I'll try and stick to the data related to IBD for our discussion and focus on monotherapy and why it is a very acceptable approach for patients. And then, one of the difficulties with debates is there is a lot of diversion and distraction and unfocus. We'll come back together, and I think there are certain consensus that we can make. But I'll look at the elephant in a somewhat different manner. This is the data regarding infliximab with or without immunomodulators in patients with the pivotal trials of both Crohn's disease and ulcerative colitis, the ACCENT study in Crohn's and the ACT study in ulcerative colitis. The patients enrolled were those who were failing therapy with salicylate, steroids, and/or immunomodulators, and we have data whether or not there was impact based on whether the patients were on immunomodulators or not. So amongst those, the patients were not randomized to combination therapy, and the trials were not powered to evaluate combination therapy, but there was no difference in the outcomes of patients whether or not they were on combination therapy with infliximab and azathioprine, period. As Brian points out, one of the benefits of combination therapy, or one of the effects, I would say, of combination therapy is higher biologic drug levels, and we've seen this across the board, and lower risks of immunogenicity. But we always need to keep those aspects in the context of treating the patients, along with, as Brian's already alluded to, the individual risks. Now, we have recognized, and Brian's has alluded to this, the impact of low trough levels of drugs. First of all, the disease comes back. We assess patients for active disease. If they lose response to agent A, B, or C, and they have low drug and no antibodies, we raise up the drug, and that usually ameliorates the symptoms in the individuals along the algorithm that Brian showed. Low trough levels are one of the factors that are associated with the development of anti-drug antibodies. And here I agree with Brian that both of these are bad. And my point is going to be keep the levels up. Brian's alluded to the SONIC data, which is the best data, prospective, for combination therapy for 1 year, 6 to 12 months, in patients with Crohn's disease who were naive to immunosuppressives and naive to biologic therapies. And indeed, there's a difference. There's a 12 or 13, I'll give him 13% difference in combination therapy versus monotherapy. When we talk about number needed to treat, for that 13% advantage, it means that we are going to need to treat 7 patients with combination therapy versus monotherapy with infliximab to have 1 patient benefit from it. So the number needed to treat is 7. About 20% of patients don't tolerate azathioprine for one reason or another. Not having the serious reactions, but just the nausea, vomiting, allergic reactions, or whatever. 20% is a number needed to harm of 5. So the number needed to harm is actually less than the number needed to treat in mono versus combination therapy based on the SONIC study. Now, let's go back to drug levels, because Brian focused on this, and I think that, again, this is going to be the focus of my discussion. In the what's known as the ACCENT study, and I'll remind you, because this was now published in the over 10 years ago, patients who responded to initial Crohn's disease, responded to an initial infusion of infliximab, were randomized to maintenance therapy with infliximab versus switching over to placebo. And of course, this was the study that led to the approval of maintenance infliximab in patients. We took a look back, just as we're going to look back at SONIC in a minute, at the patients in this, and of the individuals who had good drug levels at the end of 14 weeks after the 026, those were the individuals who did well in maintenance therapy. In contrast, the patients in ACCENT who had low drug levels at the end of 14 weeks, just after induction, were patients who either required dose escalation or failed therapy with maintenance infliximab. So we can use this as a predictor of the long-term response. And again, the persistent remission was twice as much in the individuals who had adequate drug levels compared to those who did not. As Brian's alluded to, we've seen very similar results with adalimumab. With adalimumab, patients who had persistent drug levels had less likelihood of losing response along the way compared to patients who had lower drug levels. And this is actually from a different study from Europe that also looked at drug levels at the end of induction more prospectively with infliximab, and again demonstrated the same thing that we saw looking retrospectively in ACCENT, was that patients who have good drug levels at the end of induction tend to do well. And this will move into our discussion of optimization along the way. Now, Brian showed one slide from what's known as the DIAMOND study. This is a Japanese study in Crohn's disease that was essentially kind of a SONIC version with adalimumab instead of infliximab. And in this study, patients were randomized to receive adalimumab alone versus adalimumab in combination with azathioprine. And as far as their primary endpoint, which was clinical remissions, there was no difference in outcomes in combination versus monotherapy. Brian did show this one slide, but he said it's really hard to interpret the Japanese descriptions of the endoscopy, which showed a slight favor to combination therapy as far as endoscopy was concerned, but again, it did not impact on the clinical outcomes of this. And indeed, even in this study, patients treated with combination therapy did have less immunogenicity to adalimumab than patients treated with monotherapy. So actually, there's a little bit in favor of Brian showing the reduction in anti-drug antibodies even with adalimumab. Now, Brian also was an author of what's known as the COMMIT study in Crohn's disease. Now, in this study, was looked at patients who were treated into remission initially with corticosteroids and then maintained with infliximab alone or with infliximab with methotrexate. Combination study. And here's the data. These lines are not separable. There was no benefit of combination methotrexate in this study. Brian will agree, in patients who were induced into remission with steroids initially and then randomized to combination or not. And then finally, Brian did already show this study in ulcerative colitis, which looked at essentially the mini version of SONIC of azathioprine alone, infliximab, or the combination. They did demonstrate some benefits of combination therapy, but interestingly, azathioprine was as effective as infliximab in this study. Let's see. I'm going to skip this slide. When we talk about the risk of anti-drug antibodies, and Brian's already alluded to the importance of the pharmacokinetics of the biologic agents, there are a number of factors that impact on the kinetics that also include anti-drug antibodies, but there are other factors as well that impact on how rapidly these drugs are eliminated. Now, there's a bit of a chicken and egg in here, because if the drug is rapidly eliminated for other reasons, there's still a risk of anti-drug antibodies, because rapid elimination is one of the other risk factors for anti-drug antibodies. We do know that combination therapy will improve the pharmacokinetics, and that's an area of agreement between us. But now let's go back and look at the real risks. No one is going to see lymphomas in the first 6 to 12 months of combination therapy. That's unlikely in a group of several hundred patients to actually see an uncommon event like that. Nevertheless, and Brian said, everyone gets combination therapy. Is there a pediatrician in the house? Pediatricians are no longer using azathioprine, and I see an agreement from a singular member of our youth organizations here. So there is a risk related to that, and in particular, it's not a risk of elderly. The risk of lymphomas with azathioprine are exaggerated also in young and in particular male adults, although it does increase in age. And although the risk of hepatosplenic T-cell lymphoma is rare, the risk of progressive multifocal leukoencephalopathy with natalizumab is rare. Is anyone giving natalizumab now? Nobody, okay? So bad, rare events certainly drive not only our opinion of medications, but the patient's opinion. And in an era of shared decision-making, this has been the #1 impediment to combination therapy, at least in my experience. So what's happened over the years is there's actually been this pendulum. When infliximab was the first drug and the first and only biologic that we had available, we learned from the pivotal trials that there was no advantage to combination therapy, yet we had the insight on the kinetics of higher drug levels and a reduction in anti-drug antibodies. So although we saw that there was no difference, we still advocated combination therapy because that was our last-ditch effort, and we wanted to put everything we could because we didn't have anything to fall back upon after infliximab at that time. But then several things happened. We recognized the risk of lymphomas that were related to thiopurines, and then there were several cases, rare but important, of hepatosplenic T-cell lymphoma. And our attitudes changed because then we had adalimumab available and subsequently other biologics. And as you heard the pediatricians, they walked away from azathioprine, not willing to take that risk, and in the fact that there was no advantage. Until we came to the important, and I will advocate that the SONIC study was very important. It looked prospectively at the retrospective analogy. It was a different group of patients. It was not patients who were failing therapy or not responding to azathioprine, but a group of naive patients, and clearly demonstrated benefit and low risk, at least within the first 6 to 12 months, but that leaves the door open to the long-term consequences of azathioprine, including skin cancers as well as the risk of lymphoma. And so as we've evolved and our therapeutic options have evolved, this pendulum has swung back and forth, initially initially combination therapy, more to mono, then with the advocacy of Brian and Bill Sanborn and others of combination therapy. But this becomes rather complicated along the way. We've seen these different factors, and I think that they've all modified us. Now, we've seen the benefits of combination therapy, which is higher drug levels. The negative aspects are now we have to monitor 2 different drugs. In SONIC, a fixed dose was given of azathioprine at 2 to 2.5 milligrams per kilogram, as in most of the clinical trials. But in my opinion, giving a fixed dose of a drug that has a genetic polymorphism in its metabolism related to thiopurine methyltransferase, where everyone's going to have a different level, as we're going to hear a little bit later from Dr. Afzali, it's a ridiculous concept to give a fixed dose, and we do need to monitor now 2 separate drugs. And the risk of immunosuppression, well, is this synergy or is it just drug levels? And of course, we do have risks of immunosuppression along the way that have been well defined. Now, we're also going to be discussing, and I think more in the panel, the risks and benefits of stopping combination therapy. The benefits of stopping the azathioprine may be reducing the risk of lymphoma, but then the other risks are disease flare and disease progression, and we've already discussed that important aspect. So which patients should receive combination biologic and immunosuppressives? Well, patients initiating a first biologic after failing in immunosuppression, I tend to follow what Miguel will do. I'll treat with combination therapy for the beginning, but then most often I will begin to withdraw one or the other. Most often it's the azathioprine, because I think most of us feel that while the biologic is more expensive, the risks seem to be more from the immunosuppression. Patients who have developed immunogenicity with one agent and are losing response, we're most often going to give combination therapy with that next agent, because individuals who develop anti-drug antibodies, it's their nature to develop it to others, even though there may be less inherent risk from one agent to another. And then the other group is, if you're not going to use therapeutic drug monitoring, along the lines of Sonic, then I very much agree with giving combination therapy in that group. But that's not who we tend to treat. I do not give combination therapy to teenagers or young males unless I'm doing it for a very short period of time, and we may substitute methotrexate for azathioprine in that group of individuals. We already talked about the elderly who are at increased risk for both serious infections and complications of immunosuppression, and as well as lymphoma. So I think that we've identified benefits and risks along the way, and then we need to get personal with our individual patients. Thank you, Scott.